I don't want the Maryland Healthcare Commission to take credit for this, but I do want to say that we did look at what Shore had been trying to do, and we recognize that given the intensity of feeling, that even if the perfect solution were crafted, and I don't even want to say what that is, that we felt as though there had to be a broader, more independent group of people, including with broad community input, that participated in this. And so we applauded that. We realized that we and other state agencies are going to have to, this is not a time where there's a lot of money to do much in government. We're very prudent and efficient, as we try to be, but I think this was an important group to convene. I think it was important that it be broad-based. I think the input we got was we want to have representation across the region with different perspectives, but no set solutions, predetermined solutions coming in. We think it's important. We've heard lots of criticisms of our selections, which I think that's fine. Other people can differ on who should be on it, but we really wanted it to include all 5 counties because we think the solutions, and I say that specifically, are going to have to incorporate all of 5 jurisdictions if we're going to really solve some of the challenges that are out there. And we're really going into this, we don't have a secret template here where we're trying to push this work group. We think the fact that it is chaired by 2 individuals that are independent but reside in the region will ensure that the maximum amount of openness and transparency are just part of that process. I mean, what I would say is the general decline in inpatient utilization is something that we've been aware of for probably 8 or 9 years, and it's consistent with what we see in Maryland is consistent with what's happening across the country, where inpatient beds are not needed to the degree they once were, partially because services can be provided in an ambulatory setting. The challenge is that in a lot of smaller hospitals, and these tend to be smaller and rural hospitals, if you have 40, 50 licensed beds, you see a deterioration in occupancy, and at some point it becomes very challenging to continue to operate. So if you're a 350 bed hospital and see declining occupancy, you will in Maryland see fewer beds, but in a rural hospital with 50 beds, at some point it becomes very challenging. And there's of course much debate on why that's occurring. Is it simply this trend towards ambulatory services, or is there conscious efforts to migrate services elsewhere? I think the interesting thing about the Midwest was that there were lots of hospitals and people wanted to preserve those hospitals, but they drove around them when they were acutely ill, and that probably exists today. I think that in terms of the palliative care issue, that the model that's been talked about now, Kent County will be Shore can't do anything until July 2020 in Kent County, but the model that's been talked about is more generally is a freestanding medical facility, which translates into an emergency department with supporting ambulatory care services, one of which would be the ability to offer observation stays, which seems especially appropriate for a aged population. This is being discussed in Laurel and in Harford County, where perhaps people at a nursing home would present with conditions that perhaps warranted a admission. They would be taken to one of these freestanding facilities where they could be observed for 1 or 2 days. If their condition mitigated, they would return to the nursing home. If it was a judgment of the physicians at the freestanding facility, they would be transferred elsewhere in the case of Harford County, Upper Chesapeake in the case of Laurel, perhaps to Prince George's Hospital Center. So that, I mean, I think that's the model around it now. The vision increasingly is these ambulatory campuses, which include medical arts buildings, a diagnostic suite, which would include advanced imaging, perhaps even other services. So it's, in larger urban areas, certainly the concept of an ambulatory campus is, I think, somewhat appealing, especially when you're replacing an aging hospital, and a system's coming in and saying, we're going to make a $20, $30, $40 million investment for you, and these inpatient beds, we are going to keep them from the standpoint of observation of some of them, but the ability to provide acute care here is going to disappear. But a very modern ambulatory campus is our vision, and I think that can be appealing if it's done appropriately and the appropriate services are configured at that site. So the report is due to the legislature in September of 2017, and it will be, ambitious to get all this work done. We did get some funding to identify a research organization. We're using the University of Maryland in collaboration. We hope to use the University of Collaboration in collaboration with a rural research center at one of the federal government approved research centers across the country. That hasn't been finalized yet, but I think there definitely will be one of the federally designated rural research centers that will be participating in the group.
So, I mean, that might help a little bit, but you've got to not only get that research, but you've got to explain that research, and you also have to come up with a consensus.
Don't scare us. Don't scare us. I think that is, and it's not the only thing we're doing right now, but yes, it's going to be ambitious, and our thought was we didn't shy away from picking people with strong opinions, but we will be asking at the first meetings to really think about how we can generate consensus and a focus on thinking about solutions for the region. And like any region, I think that's challenging when all of us think of us as our local jurisdiction, our local elected officials, which largely are county anchored, and how do we move from this, where I get my fair share on a regional framework. That's a challenge for the midshore. That's a challenge for the capital area of Maryland as well as the Baltimore region as well. Well, I don't want to preclude anything from the work group, but I think the point is that we are looking at transportation issues. I think today every jurisdiction wants a hospital. I think I would ask jurisdictions to say we want high quality services. If we have a hospital, it's not just a inpatient access that we care about. But I think the fact is that transportation represents a significant challenge in what we quote unquote call rural Maryland, particularly the shore, where we have this influx of tourists over a 5-month period, and when that has to be considered, what it's going to look like for the jurisdictions in the midshore, because simply stated frankly, rural communities across the country do operate with a acute care hospital more than 30 miles away. Do they operate with sort of the transportation challenges we face on the Eastern Shore? Not so much, and that has to be a factor that we look at how we're going to solve that. I don't think that we've dodged the point that transportation is an important variable here that doesn't exist elsewhere. The study that's part of this, we see this as really two phases or two activities. One, the study that will be used by the work group, and then the work group deliberations that would spring off of that information and other public input, other information that may be evolving as a result of this new hospital model we have could guide that process. I really see this as what's happening with this next version, and we haven't really talked about this, is that the state is preparing to submit a new step 2 in this global budget process, in which we would look to really bring more types of providers under this value framework. And how that goes, I think, will go a long way to telling us, what type of system we'll be recommending, the work group will be recommending going forward. Because I'm going on to this with, in some ways, a clean slate on this. I mean, I think if you look at the issues we have to consider, workforce, access to broad populations, but I think clearly focusing on vulnerable populations, the elderly, those with behavioral health problems, those chronically ill. I think they're going to see, how are we going to do this, and going back to the transportation issues, which are outside the framework of healthcare. Generally, when we look at that, we consider that as a external variable. We can't in healthcare, nor would I encourage, given the framework that the health system generally builds on, which is an expensive framework, that we would want to engineer that from this perspective of what's needed. But I see, I guess I see some of the challenges related to transportation and economic development as maybe bridges that will be very challenging to overcome. But at the same time, I don't see the economic development issues as daunting as we might see in other parts of the country, because as far as I know, no health system has come to the Healthcare Commission and said, we're going to close. They've talked about conversions. We're talking about, we want to have a footprint in these communities, but a different footprint. And I think where you will see the biggest economic upheaval is when systems pull stakes and leave completely. I see a way forward. I'm hopeful. I think we need to be pragmatic, but we need to be hopeful that there are solutions. We have tools that no other state in the country has, and I think they can be brought to bear on this challenge, where it will depend on people of goodwill working together. This is an opportunity for the Mid-Shore to really demonstrate that the region can come up with a solution. Not that there won't be challenges, but I think we're hopeful that this is, as Senator Middleton said, a template for other parts of the state. So we have to bear that in mind. Yeah. I'm hopeful. Yeah. I'm truly hopeful.
Looking back, when you say economic development challenges, what does that mean?
So I think that there's been a lot of, two things that people really talk about are closures. How does that affect the quality of care? I think that certainly in urban areas, by the time a hospital closes, doggone it, it should close. There's less evidence in rural areas one way or another, but clearly when you pull up stakes in a rural area, you're pulling up the largest employer. And I think people really, and that's an anchor. You take away my school, which is what I think maybe defines a community even more than a hospital, but it's up there. And we understand that that's something that's really mindful, and it's the way we reference ourselves. We have our hospital, it's part of the voluntary philanthropic efforts in a community that are really, really important to defining who we are.